All right, good evening, everyone. Want to thank you for coming to tonight's Queen's Speaking of Health lecture series. Tonight's lecture is called An Infection Can Lead to Sepsis. Are You at Risk? My name is Lisa Zakia. I'm with Corporate Communications here at the Queen's Health Systems, and on behalf of Queen's, I welcome all of you this evening. It is now my privilege and honor to introduce you to Dr. Garson Lee, who is an internist and hospitalist here at the Queen's Medical Center. He was born and raised in Hawaii, small kid time, but he attended high school. And everyone always wants to know what high school did you go, right? Okay, he attended high school in California, but I'm sure you still want to know, right? He went to Archbishop Mitty High. Anyone? Yeah, okay. He earned his bachelor's in genetics at UC Berkeley. For medical school, he came right back home to attend John A. Burns School of Medicine and completed his residency in internal medicine with the Hawaii Residency Program. He is board certified in internal medicine. Here at Queen's, he is the Associate Medical Director for the Hospitalist Group. He is also an assistant clinical professor at the John A. Burns School of Medicine. He noted that one of the reasons why he returned to Hawaii was to windsurf, sail, and cycle, and since that time it has evolved to chauffeuring his children to baseball and basketball games. So please join me in welcoming Doctor, Professor, and Child Chauffeur, Dr. Garson Lee.
Thank you for that wonderful introduction, and really thank you all for coming here today. Especially it's pretty hard on a bright, beautiful sunny day out there, so I really appreciate you spending your Wednesday evening with me. So I'll give you some background about sepsis and why sepsis. Sepsis is pretty well known in the medical community, but outside of that, little is known about it. The unfortunate thing about sepsis is it's actually increasing in rates. It's like 6% every year. And it's one of those diseases that you could really help curb the mortality just by mere education, early recognition, intervention. So your presence here is very important. So I really appreciate you all being here. Okay, so let's start off talking about sepsis. I want to go through a case study to kind of illustrate what happens when a patient comes through with infection. So prior to all this, I was a private practitioner. I had my own panel of patients, and this is one of my patients early on. So she's a 52-year-old female who thinks she's invincible. She's pretty healthy with no medical problems. The thing about her is like she loves to travel, and she goes to Machu Picchu, Brazil, Japan, so she has lots of fun. So after returning from trip one day, she's been having a minor cold, runny nose, earache, sore throat, the usual. Like most healthy individuals, she's hesitant coming into the office. She said, I'm having this cold. Would you mind just calling me some antibiotics and I'll be fine? So I inquired more questions. So tell me about what else is going on? She said, the cough is kind of yellow, greenish sputum. She's starting to have some chest discomfort, and she's starting to have shakes or rigors, and lightheaded at times. Knowing that her symptoms are progressively getting worse, I kind of advised her, maybe you should come in. She hesitated, so finally she says, okay. It wasn't until 6 o'clock that she ended up in the ER. So let me tell you what she looked like. She looked pale. She looked up at me once, and then she kind of went back to her self and just kind of looked down. She could barely talk. I touched her, I felt her pulse was beating pretty fast, and she was breathing pretty hard. Her blood pressure kept on dropping to the 80s or 50s. We had to give her a lot of IV fluids to kind of bring her blood pressure up. And her white count was pretty high, 25,000. So kind of look at an x-ray, if you look at it, her x-ray, most of the part, it's pretty clear except for that. If you look here, this is the heart, and this is what your lungs should look like. And this area here is this whitish area. So that's what we call left side of the lung with an infiltrate. that signifies that that's something they're occupying that space. So that's likely a pneumonia. So what a pneumonia is, an infection that's occupying the lung spaces, and that's what's going on. So right away I started on IV fluids and put her on some strong dose of antibiotics. Because her blood pressure kept on dropping, we had to put her on some vasopressors. In the hospital, when the blood pressure drops, they need extra strong medication to sustain the heart from pumping stronger and faster so that it can have adequate blood pressure to the rest of the body. But because she required this, she had to be admitted to the ICU. So while she was there, I called my colleagues, make sure everything's fine, make sure I got the right antibiotics, right antibiotic treatments. I called my ID specialist, and they all confirmed everything's fine. There's not much more you can do. Just kind of give it some time. So I went home, hoping hopefully I'll see her the next day and see how she's doing. Unfortunately, at 3 o'clock in the morning, I get this call from the ICU, and when you get a call from the ER, it's one of those calls you kind of dread. So I asked him, what happened? He said, I'm sorry, but your patient passed. So he said, the blood pressure kept on dropping. We couldn't sustain it. Her kidneys started to shut down. Her liver started to shut down. She went to shock and then went to cardiac arrest. We tried to resuscitate her, but after 30 minutes, she just didn't turn around. So that's very unfortunate. So of course I was devastated. This is one of my favorite patients, and she just unfortunately passed. So a lot of the questions were going through my mind. What does she have? Why was she so sick? Did she get the right treatment? And could this have been prevented? So for the next 30 minutes, I'll go over some of the objective. What is sepsis? What is its pathophysiology? How do we diagnose it? How do we treat it? And how to prevent it? Okay. So let's talk about some quick history behind sepsis. Sepsis was first described by Hippocrates in 460 BC. It came from the word "sepsi," or meaning to make rotten. In the olden days, there was no hygiene, there was no antiseptic, there was no antibiotics. In fact, penicillin wasn't discovered until 1928. So whenever a person gets a wound infection or they did a surgical wound, the bacteria would get in and it would become red, hot, swollen, and become gangrenous and dark, and eventually the patient passes. So that's what happened in those days. So let's take a look at the microscopic level. What is actually going on inside the blood vessel? Okay, so your body has a pretty remarkable system to fight off infection. So whenever you have an invasion of a microorganism into your immune system, an inflammatory process occurs. And so what goes on is your white cells, which is one of your cells that fights off the infection, recognizes that this doesn't belong here. It secretes a lot of chemokines or cytokines. And what that does is try to recruit more white cells to the area to fight an infection. It does this by causing blood vessels to dilate and blood vessels become leaky. So what's happening is all this blood is rushing to that area and it's causing a swelling. And so on your skin, if you ever get infection, you notice it's red, hot, swollen, and tender. And so that's how they kind of fight off the infection. But in sepsis, it kind of progresses to a more inflammatory process where it spreads out throughout the whole body. So instead of just a skin or lungs or different areas, it goes throughout the whole body. So imagine this. You don't have enough blood in your blood vessels. All of it's leaking out. And on top of that, your blood vessels dilate. So what's happening is your blood pressure is actually dropping. And so it needs to figure out where should the blood go. So it shunts to the most vital organs, which is your heart. And so it compromises flow to your other organs. And that's why your kidneys shut down, your liver shut down. And then when there's enough blood to your brain, you become a little lethargic and confused. So that's actually all what's going on. And eventually your heart just can't keep up with the demand of getting that blood to the rest of the body, and it goes into shock. And when you hit that degree of severity, that's when mortality hits. Now, some basic epidemiology. Sepsis is one of the leading causes of mortality and critical illnesses worldwide. It's actually more than heart attack. It's more than HIV, AIDS. So it's a pretty big thing out there. It affects more, there's a more than 1 million cases of sepsis each year, and it accounts for 258,000 deaths annually in America. The mortality rate 30 years ago used to be 80%. Now, that has dropped down to 30 to 50%, so there's definitely room for improvement. In terms of cost, it costs billions and billions of dollars and is one of the third highest consumer of Medicare and Medicaid. So CMS is very interested in trying to fight this disease here. So how do we diagnose it? In 1992, the International Consensus Conference came up with a diagnosis, and it said, sepsis is defined as if you have an underlying infection that causes an inflammatory response, okay? So inflammatory response is defined as two out of the four things, either fever or hypothermia, so either a temperature greater than 100.4, temperature below 98.6, rapid heart rate that's greater than 90, rapid breathing rate greater than 20, and elevated white count, high white count greater than 12,000 and less than 4,000. So that's pretty technical, but that signifies that your body is trying to compensate for the diffuse inflammation that's going on. Okay. Now, sepsis comes in varying severities. Okay. So it starts with mild sepsis, which is inflammation with infection, and as it progresses to compromise the organs such as kidney failure, liver failure, that's when you have severe sepsis. And of course, as it progresses to septic shock, that's when you have a drop in blood pressure. And a lot of times, these patients need fluids or, in fact, pressors, and mortality rate at that area goes above 50%. So the idea is trying to recognize and treat early to prevent you from progressing to that stage of the disease. Okay, so the problem with diagnosing sepsis in most individuals is trying to differentiate, is this inflammation or is this an infection? So I have a picture here. If you look at it, it has the telltale signs of an infection. There's redness. It's warm to touch. It's swollen. You can tell it's definitely swollen. And when you touch it, it hurts. But this picture is not a picture of a infection. It's actually one of the common tourists that comes off the plane, goes on the beach, and has a severe sunburn. So pictures, you can't tell everything just by looking at the picture. But it's a very different story if I said the same man is not your typical, it's a tourist, but he's a homeless man. He's been walking on the beach for the last 2 weeks barefoot with cuts underneath, you just can't see it. Then I would say, hey, this person probably has a pretty bad infection. So as clinicians, what we need to learn, what to know from you guys when you provide us a history of what's going on is, how did it start? Did it come from a bite, a cut, a bug bite? Where were you in the ocean? What's the surrounding condition? And the most important thing is disease progression. Now, with most sunburns, it stays flat for a while, and then it gradually gets better over a period of 2 or 3 weeks. Infection is slightly different. Infection, it rapidly progresses and spreads up, it gets worse. So those are the things we need to know. So we need to know the time course as well. A lot of times what we do in the hospital, if we see this, what we do is we tattoo you, just get a Sharpie mark and draw the borders to see, that we can tell whether it's getting worse or getting better, if it's progressing or receding. Okay, so who are at risk? The people at risk are usually the very young or very old, or you could think of people with decreasing immune system. The very young has a premature immune system, so they're more at risk for secondary infection. On the opposite end, the people that are very old, unfortunately, in addition to all the comorbid illnesses like COPD, lung disease, heart disease, their immune system is starting to weaken a little bit, so they're at increased risk. If you look at the data, 2/3 of those people that have sepsis are over the age of 65. So that's another risk factor. Other people with weakened immune system, that includes people with like rheumatoid arthritis, lupus, other connective tissue disease, and people with chronic illnesses, diabetes, kidney disease, liver disease, AIDS, and cancer. The reason why the liver is, if you think about it, liver is one of your screening process. It has a lot of white, what we call Kupffer cells, that is a primary defense in preventing secondary infection from transmitting through. So if your liver's not there, it can't really fight off the primary infection, so that's why that's crucial. Cancer, your white cells, sometimes they have lymphoma or you have leukemia. They produce a lot of white cells. Even though there's a lot of white cells, it doesn't mean those are good, healthy white cells. Those are white cells that's not pretty functional, so that's why they're more prone to infection. Now, your skin is your primary defense mechanism. So people with minor burns, that's not too bad, but imagine if a large part of your hand is burned, like 30% or 60% of your body burned, you lose a large part of your primary defense mechanism. So now you lose the protective barrier, but you also lose fluids and other problems. So you're at more risk for infection with wounds and even severe sunburns without appropriate hygiene. Now, the last piece is patients with invasive foreign devices, okay? The foreign devices are people with pacemakers, heart valves, or prosthesis, or prosthetic joints. Part of the reason why foreign objects in your body is dangerous is because bacteria loves to adhere to the joints or foreign matter. So it sticks to it, and antibiotics just won't cure it. So in order to fix those problems, that thing has to come out. Because if it adheres to it, you give antibiotics, it's not going to kill it, but it keeps on growing on the foreign object, and it slowly releases bacteria into your bloodstream constantly. So that's why you have to remove that object if you do have foreign devices. Okay, moving on, prevention. So one of the key things about prevention is hygiene. So what this picture is on one side, just to show an analogy what's going on one side is a bunch of zombies on the fence, and on the other side is a little guard that's looking after the zombies. You know how scared that guard is? So you could think of hygiene as very similar to this fence here. Your skin is that defensive barrier. You have all these microbes on the other side trying to get into your skin. So if you don't routinely have good hygiene, your chance of infection is a lot higher. So it's very important to have good hygiene. But on the opposite end, too much hygiene is also bad, because if you keep on scrubbing with antiseptic, all these things, you're going to erode your primary defensive barrier, your skin, and that increases your chance of infection. So everything in moderation is appropriate. Now, the other part of hygiene is also hand hygiene. We strongly emphasize that in the hospital. When you come to the hospital, always say wash your hands. We always say wash your hands before you see the patient, and wash your hands after the patient. So if your doctor doesn't do that, make sure you remind them to wash their hands. If you think about it, remember one of my professors used to say, if you ever drive and you come to stop, like look around, there's always someone picking their nose. And when they get out of the car, what do? The first thing they do when they greet you, they shake your hand, right? So you're passing that germs on to the other person, and it stays viable for quite some time. It depends what kind of organism it is. And then a lot of times when they have that itchy nose, you can rub it on your nose, and you just transfer that organism. That's how people transfer organism. And so hand hygiene is very key. And that's what I like to do with knuckles a lot of times instead of the handshake. And of course, obviously avoid exposure to sick contacts. So when you see some of the sick, kind of stay away. And there's a distance you want to keep away from, like usually 6 feet or so. That way you could help protect yourself from getting those diseases. And a lot of things are airborne, and if they're airborne like TB, definitely try to stay as far as you can. The last piece is vaccination. The importance of vaccination is usually helps to build up your immune system. So how a vaccine works is that it creates particles or antigens. Antigens are particles on foreign object that stimulates immune response. So each virus, bacteria has a specific region that your body recognizes. And what we try to do is produce that region called peptide or molecular the peptide or pieces of that organism, and we inject it in your system. And what your system does is build antibodies against that activity. So it heightens your immune system. So when you get an infection, what it does is it help reduce the burden of infection. So a lot of times I hear people say, hey, I got the flu shot, and guess what? I still got the flu. Yeah, that still can happen. But if you think about it, if you didn't get the flu shot, that infection may be 10 times worse, and you may not have left the hospital. So it does help. And also, why we vaccine, like flu vaccine, sometimes you vaccinate every year, and pneumonia every 10 years. Part of the reason is the organisms, the virus, the bacteria, they're pretty smart. They kind of mutate pretty rapidly. So the flu virus tends to mutate pretty quickly. They have this thing called transgenic shift, so they mutate so quickly that the body doesn't recognize it after a year. So that's why we vaccinate with flu vaccine every year. Pneumonia, they're a little more steady, so they don't mutate as quickly. So that's why you don't have to vaccinate as frequently. Okay, now treating sepsis. How do you treat sepsis? This is one of the key things. In 2002, they looked at this one study done by Rivers in 1991, and he did a remarkable study. He was an ICU doctor, and what he did was look at these patients with sepsis, recognize them really early on, gave them a lot of fluids, and make sure their blood pressure is okay and is perfusing well, and give antibiotics within 3 hours. And what he saw was mortality from sepsis decreased by almost as much as 15%. That's pretty remarkable. That's done without any new technology, any new medication, any new agents. It's just early recognition and treatment. And that's why your presence here is important, to recognize these symptoms early and get help early. So they want to improve this by putting a set of protocol called the Sepsis Bundle. And so the Sepsis Bundle is this, and we abide by this. And as of October 2015, they require all hospitals, all long-term care facilities to report on how well hospitals are following these sets of protocol. So what the protocol is, the 3-hour sepsis bundle, they recommend you initiate the appropriate workup early, which is get blood cultures, get lactic acid. Lactic acid is a measure of, is the organ starting to shut down? It's a sign of early organ shutdown. Start antibiotics as early as possible, within 3 hours. And if you think about it, the more the antibiotics sit, the longer the virus and bacteria sit in your system, the more chance it has to create damage. So this one person looked at what's the risk of, what's the relation between antibiotics administration and mortality? And he found that each hour delay in given antibiotics, mortality went up by as much as 8%. That's pretty remarkable. So if you treat it within 3 hours, 2 to 3 hours, you could actually help you improve your survival. So that's really key. And the other piece is give necessary hydration within a very short amount of time. So tissue perfusion is key. So what the whole goal behind it is, you want to prevent the organ to shut down, right? So you give hydration early. And if it's not enough, if it still keeps dropping, that's when we start vasopressors, as what we did in the lady, okay? I didn't think that this would be such a big deal. So we started this sepsis alert system at Queen's Hospital. And so whenever you come to the ER, the nursing staff are very well trained to recognize the SIRS, the inflammatory response, and possible source infection. And what they do is call code sepsis. And you see tons of physicians just writing in, well, maybe just 1 or 2. But the nurses come in and they get things ready. They get the blood test, they get the workup ready, and they give the fluids and antibiotics. And they were able to do it 3 hours, okay? So there shows 2 lines. There's the gray line and the blue line. So the gray line says these guys didn't fulfill, like they fell out of 3 hours. And the blue line, they made it within 3 hours with all those 3-hour sepsis bundle, which is the IV fluids, antibiotics, and the appropriate workup. And just by doing that alone, the mortality dropped by 10%. That's pretty remarkable. So there's definitely ways to improve. And so you think about it, the earlier you come in, the better your chances are overcoming this. Now, a common thing I get that's also frustrating equally, hey, if antibiotics work and antibiotics are beneficial, why not just throw antibiotics on everybody? Sounds like a good idea. But the study has shown that 30 to 50% of antibiotic use in humans is unnecessary or inappropriate. 47 million of antibiotics prescriptions are written unnecessarily every year. The big problem is there's increasing antibiotic resistance. Okay, and so every 2 to 3 months, we get reports from CDC that there's this strain of bacteria that's becoming resistant to this antibiotic, and it's pretty frequent. The scary thing about all this is that the drug companies, because they're capitating the costs and the profits, so they're not incentivized to produce new drugs, and they're coming out with new drugs less frequently, like maybe two every year or so. We're not catching up to the increasing antibiotic resistance. So imagine you come in and there's nothing we can treat you with. That's pretty scary. And there's this concept of dysbiosis. What it is microbial imbalance inside your body. So what your gut has is have a very healthy balance of good bacteria and bad bacteria. So when you take a lot of antibiotics, you're going to kill off a bunch of bacteria. And unfortunately, a lot of times you kill off the good bacteria. And so when you kill off all the good bacteria, the bad bacteria has no competition. They could flourish like crazy. They just, like weeds, they start growing. And so we've been seeing like increased problems with Clostridium difficile infection. This is one of those bad bacteria that thrives and causes really bad diarrhea and really bad stomach pain. And that is very hard to treat. And so that's been on a rise. And you sometimes see why people take probiotics. The reason why is they try to maintain a healthy flora in your gut. And so sometimes taking probiotics before helps. So that's another problem with overuse of antibiotics. So the question is, when do you give antibiotics and when don't you give antibiotics? I think your clinician can work with you and guide you what to look out for. Remember, to differentiate infection versus inflammation is very hard. There's a gray line. So the things we need is, and you could work with the physician, collaborate what to look out for is like, do you think it's infection or not? What are the chances, what are the risks? And then look at how the disease progresses. Okay, I'll give you an example. Like people with chronic obstructive pulmonary disease, a lot of times what it is their lung isn't working as well. Right? So in general, those people are just more prone to infection than other people. A lot of times they come in shortness of breath. Reflexively in the past, we just throw them on antibiotics all the time. But they've trained us to be a little more smarter, to look at certain things. So our rule is if the patient has fever, has cough with yellow greenish sputum, and the sputum production is different from their baseline, then it's most like an infection. If it's not those symptoms and it's just like mild shortness of breath, see if it gets better on its own. So we can't tell you throw antibiotics here just right away and you take it. The key thing is what your suspicion of antibiotics and work with your physician and maybe go on trial without it. If it gets worse, definitely put you back on it and see if that helps. So that's what we need to see. The response to the medication, is it getting better, is it getting worse? And so that's what we need to guide us. So that's what we're recommending is collaborate with physicians, see what the chances of that is a bacterial infection and treat accordingly. Okay, hospitalization versus staying home. A lot of times when people come to the hospital, they want to stay in the hospital. They don't want to go home. They're afraid to go home. And that's pretty common. I get that. But the whole thing is, remember when I talk about sepsis, there's different severities. There's mild infection, severe sepsis to septic shock. Severe sepsis, septic shock, you definitely should be in the hospital because we got to treat that more aggressively. A lot of people come into mild infection, okay? So how do we determine whether you should be admitted or not? I think I get that question a lot, okay? You look at the severity, time course, and progression, and maybe we do a trial treatment to see it get better and see how fast it gets better. It gets better, we put you with pills, and that's great. Now, is it better to be hospitalized or be at home? Now, if you think about it, what's the best way to optimize your recovery? Okay, the best way to optimize your recovery is you have to get good rest, good exercise, and good diet, right? How many of you sleep more than 8 hours in the hospital? That's pretty hard. You're not getting a good rest there. And what about exercise? If you're thirsty, how often you get up and get a drink of water? If you try, the nurse will yell at you and the alarms go all over the place. So you don't get any exercise, right? So it's not there. And then if you get sick, where do you go? All your buddies get sick, where do you go? Hospital. So you're exposed to a lot of infection. So hospital is not the best place to recover. So what we look at is what is the home environment. So a lot of times we ask, so what's your home environment like? Where do you live? Who's around there? What are the conditions? unfortunately, we tend to keep homeless in the hospital more because they don't have a safe home environment. That's why you see a lot of homeless in the hospital more than the healthy individual. It's not like we like them better than you. Of course, we love everybody, but just that we have to look at the parameters where they should be, whether they should be hospitalized or in a home setting. Okay, the other thing is for risk for disease progression and inadequate source control. Like I mentioned earlier, if you have hardware that needs to come out, if you have a dead skin or necrosed skin or dead tissue, that has to be scraped off. So that's how we get source control. That's how we determine what we need to do. Now, I got just 2 more slides, thanks. I hit almost the 30-minute mark. The sad thing about survivor sepsis, when they do survive from sepsis, they're not the same. And so there's a deterioration in functional status. So they're usually not as healthy, not as vigor. They don't walk as well. They've deteriorated to some degree. Their mental capabilities is not as good too. They don't think as fast. They're kind of slower. And because they're infected, there's a high risk of them coming back into the hospital. We see that a lot. So they're high risk of readmission every time we get sepsis. So the key thing is trying to avoid sepsis. So whenever you're hospitalized, you notice that a lot of times you don't go straight home. You go to the rehab for a while to get stronger, and that's probably the reason why, because you're just not the same. One of the stories I want to share with you, I had this uncle, before being hospitalized from sepsis due to pneumonia. He was pretty functional. He used to drive a car, and he used to be able to walk, without any problems. And he got really bad pneumonia and was hospitalized for 2 weeks. He was mostly bedbound for 2 weeks. And when he got better, he wasn't the same. He had to go to a rehab hospital, a nursing home, and it took him 3 months just to be able to sit up on his bed and walk to the bathroom. 3 months of recovery. That's how significant it is with this infection. So kind of going through like the dateline and finding out what happened to our patient. So we talked about what causes sepsis. We talked about what happens, what the progression, what's the treatment. So for our patient, that 50-year-old female that was pretty healthy and thought she was invincible, she developed severe low blood pressure, so she probably had septic shock and she required pressors. The other thing that wasn't mentioned, a lot of you know, there's a lot of chronic smokers out there, right? So when you smoke, what it does, it damages your lung. It causes a lot of fibrous tissue and degrades your ability to eliminate the bacteria that kind of sitting there in your lungs. So they're more prone to infection. And on top of that, she likes to travel, so she probably brought some really virulent strain from a different country like Machu Picchu. So that's probably what happened. And the last thing that's most crucial is she waited too long, So that's the key, is you want to seek medical help immediately. So if you have any signs of cold or things like that, go call your doctor, talk to them. And a lot of times they'll say, oh, you look okay, come back in 2 weeks. It's not that they just want your money. What they want to do is really look at the disease progression, see if it's getting better, how it's progressing. If you get better and you're fine, you're probably okay. But sometimes you don't know, and you may be getting worse. So they could better guide you where to go. They could direct you, come to the ER, go to the hospital. And so that's what we need, is that collaboration with the patient to educate what to look out for, what to do, and where to go. I think that concludes my talk. Thank you for your time and appreciate you all coming here.
Okay, thank you, Dr. Lee. At this time, we're going to open the floor up to questions. So if you have a question, please raise your hand, and myself or a volunteer. Oh, okay, we have a question here.
Yeah, this may be out of, maybe it isn't. You mentioned, I think for good bowel health, you have bacteria in your bowels and you should keep them going or whatever. So are there any good probiotics to take? And how about yogurt and with the active cultures and something like that? Is that in your area?
Okay, so the question is probiotics, any recommendations on probiotics? I don't have any strong recommendation one way or other. That's more of a dietitian. But I think if you have a healthy lifestyle, I think you're fine. But if you have a kind of stressful lifestyle, then probiotics may be helpful. It's not helpful when you have an active infection. It should do it before you have that infection going on. So it depends on your condition. So every person is different. Some people take it, if they're stressful, maybe it might be a good idea.
Questions? Okay, coming.
She was next, Bill. And she was next, Bill. Okay.
The doctors always say, to take all the antibiotics, like 2 weeks worth of antibiotics, even if you're feeling okay. But I'm concerned about, the superbug and taking too many antibiotics. So is that still a good thing to just take all the antibiotics you're given?
So the question is, should I take all the antibiotics that doctors prescribe? If they give you 2 weeks, should you take all 2 weeks? For safety's sake, yes. The hard part, I'll give you some background about antibiotics administration. We don't have that crystal ball to see how the disease progress. A lot of times we just look at historical data and just kind of give based on the historical data. So we're going to change from time to time. In the olden days, I remember when you have pneumonia, you used to be taken 14 days. Now studies showing drop it to 7 days, now even 3 to 5 days for mild things. So we can't really tell exactly, but without having the doctor evaluate and tell, you should take the full course. I'll give you some background on what we do. There's a lot of things we look at in the hospital and we can gauge and control. We look at the progression of the white count, progression of the symptoms, look at the progression of chest X-ray. If everything gets better really fast, we kind of stop it early. We also look at the culture results, see if the bacteria is sensitive to that one antibiotic. So there's a lot of ways we could guide the duration versus at a home setting. We can't see all those things when we're at home, so that's why we don't have a crystal ball. The other thing I want to tell you, there are some things that require longer use of antibiotics, and those are people with infections that's deep-seated and need to have deep penetration. So that's why people with foreign prosthesis, foreign objects, they need at least like 4 to 6 weeks of IV antibiotics.
I'm allergic to penicillin. Is there any type of infection that can only be cured or helped by penicillin? Or are there a variety of things so that I wouldn't be in trouble if, God forbid, something happened?
So your question is, you're allergic to penicillin. Is there bacteria that is only sensitive to penicillin? Cannot be cured by penicillin? Of course, there's a lot of variety. Oh.
Is there any kind of, God, I thought it was so clear. Is there any kind of infection that can only be cured by penicillin? Because I'm allergic to penicillin, and if I get an infection that can only be cured by penicillin, I could be dead. Okay. So that's my question.
God, sorry. Thanks for the clarification. The quick answer is no. There's a lot of varieties we can use. We have a lot of people that's allergic to penicillin, and we use different varieties.
Okay, there's one in the front there.
You mentioned that pneumonia can lead to sepsis. Right? Is that correct?
Yes. The question is, can pneumonia lead to sepsis?
Well, actually, that's not the question. But I wanted to find out, in order to detect sepsis in people who have had pneumonia before, are there any type of equipment that we should keep at home other than a thermometer to detect fever that would lead us to know these symptoms before we go to the hospital?
Okay, so so I think to summarize, okay, that's a loaded one. I think the question was, is there any other symptoms or things you look out that could lead to sepsis when you had pneumonia? Is that correct? Yeah. I think the problem with identifying sepsis, I think the symptoms are very, very variable. It's not one size fit all kind of thing. That's why we said you should consult your physician, have them guide you. So if you have the pneumonia, the quick and simple thing is just think of with anything, with any kind of infection, it leads to the exaggerated inflammatory response. So by definition, going back to that definition, it's defined by high fever, rapid heart rate, rapid breathing, those are the early symptoms of sepsis. But the other things that physicians need to know is what kind of infection, what's a comorbidity, do you have COPD, do you have diabetes, does that put you at risk for infection? And the other things that you can't tell is what we look at is the white count and X-ray of the diagnostic study, and that's why we have to refer to the ER to get that worked out.
In terms of the equipment, though, what kind of things could we test for prior to taking him to the hospital to show that?
Okay, sure. What kind of equipment that's needed before going to the hospital? I think the quick and simple is a thermometer. That's the most helpful. It'll tell you how high the fever is, and it can guide us.
Would an O2 meter help as well?
Oh, okay, that's a good one. So does the oxygen meter help? It does. It's just one of the things, but I wouldn't run out there and buy an oxygen meter because it's just one component of the many. It would be a good idea for oxygen meter if you have maybe like really bad lung disease and you have recurrent shortness of breath. But other than that, I wouldn't waste your money on getting an oxygen meter. One thing to add to your thing, a lot of the diagnosis, 90% of the time is made by clinical history and presentation, not so much the data. The data we use is help guide us to see if it's true, confirm or not. But a lot of times we make the diagnosis by the history alone and use the data to guide us or narrow it down a little bit more.
Question is sepsis contagious?
Is sepsis contagious? Potentially. So the way to think of sepsis is the end stage of an infection, right? So the question is, what's causing the infection? So that's a key thing. Is you have to go back, what's causing? So sometimes there are some strains of bacteria that's very contagious, and sometimes there are simple, minor things that are not. So it depends what's causing the infection. It's kind of hard to tell. For example, you heard the avian flu virus that causes sepsis. Now that's very contagious, right? However, let's say if you have a stomach problem, so it's for most people, the second biggest cause of sepsis is intra-abdominal infections. So you have a colitis, infected colon, that's not contagious, right? That's localized to that area. So it depends on what's causing the infection.
Thank you.
You talk about diabetes. Like my dad had diabetes, and he had a cut on his toe, and it started to slowly turn black, and then he had gangrene. But I don't think he had sepsis. He had to amputate his toe and eventually his leg. So how does diabetes? You mentioned about it tied into sepsis.
Sure. So how does diabetes tie into sepsis, or how does a cut kind of progress and get worse? Okay, the way diabetes causes injury is kind of interesting. What we find is people with high sugars a lot of times, what it does, it starts to damage the blood vessels and blocks the flow, right? So if you block the flow to the finger or the feet, there's not enough. It's very hard for the white cells to get to the area. So you think about, remember we talked about inflammation, you get this recruitment of white cells, swelling, and more blood flow to that area. Now that stuff is all narrow, so it's harder for the white cells to get to that area to fight an infection. But not only that, you need a lot of blood flow for that infection to heal. So a lot of times the wounds don't heal. And so that's why they amputate. So if you don't amputate, that infection just kind of grows and grows and it spread the rest of the body. And that's the reason why they amputate. And so diabetes control is really important for a lot of things. And that's one of the reasons why.
Other questions? Okay.
Hi, I just was reading some stuff online about this Marek protocol by this Dr. Marek in Virginia. Do you do anything using that stuff at Queens?
Sorry, I'm not familiar with the Merit protocol.
It's some protocol that this Dr. Marek came up with. Basically, it's vitamin C IV.
Oh, yeah, Merit, yeah, that's right. Yeah.
And some corticosteroid.
Yes, we're thanks. That brings. Yes, actually, we're doing that trial there. There is this Right, Dr. Merrick, that's correct. So they did an interesting study. Like anecdotally, they did a lot of vitamin C, high dose vitamin C, I think, and then thiamine was the other one they kind of added to. And the story that I think you're referring to, they gave this, and then they think the person was going to die from sepsis the next day. He kind of woke up and he did well. So here we started that trial of high vitamin C, thiamine, and then so we implement that into our protocol at this time.
Have a question there?
If someone gets sepsis, can it go away on its own?
If someone has sepsis, does it go away on its own? It can. So there's a lot of factors that look at disease progression, right? So you have to look at the patient's genetic makeup. If they have diabetes, it's harder to cure. And you also have to look at the organism and how much you're exposed to and how virulent it is, right? So you have a small cut, a minor infection, a lot of times it'll go in its own and you're fine. But if you have a big cut and they have huge disease burden, then that can progress really rapidly.
How can you determine if the patient is getting sufficient hydration, in the recovery?
Sure. There are several ways we can assess for tissue hydration. The way the consensus conference recommend assessing hydration is several things, and we document them, right? Skin color is one, right? The other thing is we do a pulse. So we feel the pulse. If we could feel a pulse anywhere, then that's pretty good. So skin color, pulse, and the third piece is what we call capillary refill time. It should be less than 3 seconds. So what you do is you take your finger and you press it, hold it for a few seconds, and let go and count 1001, 1002, 1003. If your blood returns within 3 seconds, then that's a pretty good refill time, right? If it's more than 4 or 5 seconds, that means it's not perfusing well. Of course, in the hospital setting, we have better ways to assess, which is blood pressure, and we have like capillary wedge pressure, which monitors the pressure inside the vessels. That's more the ICU base. So there are ways we could measure from a clinician point and also more objective way.
Questions? More questions? Oh, there's one up there.
I didn't hear about this word sepsis until very recently because a friend's husband had it and he was in the hospital for 2 months. And so I had to go look it up in the internet, and it said about infection. And I'm always concerned about infection because the grandchildren always says this cut, this nick, this scratch. I mean, what do you do for your children when they have all that? Do you actually put the hydrogen peroxide, or do you need the bacitracin, or what is the safest way? Because we just leave the hydrogen peroxide. But then recently I had some kind of cut, and I poured it on myself, and I go, wow, that was really sore. So now when I pour it on my small, and I go, cry all you want, that's okay. But what is the better way to take care of all these scratches and cuts and stuff?
Sure. So the question is, if you have a cut or scratch, how do I best take care of it? Before I go further, I think you guys have asked really, really good questions. All of you do. So, but going back to the cuts, I think the history is the most important thing. When we talk about what we have to know, what's a precursor and what happens in the end. So we have to know what caused a cut. Was it a clean blade, a dirty blade? Right? You think about it. If it's a dirty blade, then there's probably bacteria there that could spread into the wound. The other thing we look at is how deep is the cut? Is it going very deep or is it very superficial, right? And the other thing we ask is like, what are your other ailments? Do you have diabetes? Do you have like other immunosuppression? So that guides us. And so for most cuts, the first thing you should do is clean it. Hydrogen peroxide is fine. Alcohol burns a little bit, but that works too. But I wouldn't do that every single day because what you're doing is killing off that initial layer. And you keep on doing it, it's harder for the wound to heal. So what we do is clean it with water, hydrogen peroxide. If you want to do hydrogen peroxide, that's fine. It depends how dirty the blade was. And then after that, you could put topical antibiotics would be helpful, like bacitracin or neosporin. Or those things would help. Bacitracin is a little bit better. A lot of people have allergic reaction to neosporin. So those are some of the ways. And the most important thing is hand hygiene, right? Make sure you cover it, prevent it from recurrent infection. Now, people with diabetes or people have decreased pulse, that cut, you don't want to wait. That's why diabetics, they should go see the doctors right away, and they need to monitor it. Because a lot of times with diabetics, that cut just won't heal. It just progress, and then eventually they become gangrenous and needs to be amputated. So that's why you should always consult with your physician, have them guide you where to go.
Have a question there?
From the onset of infection, how fast can septic shock set in? So what is the timeline, or how fast can that occur?
Okay, the question is how fast can septic shock set in? It really depends on the virulence disease and the burden of the organism. So sometimes, like necrotizing fasciitis, if you've seen those, that occurs in hours. You have a cut, it gets into your fascia, which is the covering of your muscles, and it tracks. You could see it tracking within the hour, really fast. So they could be very fast, or some could be very slow. Could develop over weeks as it slowly festers. It depends on a lot of things, how well you're taking care of it, how well your immune system. So the way we look at it is look at the organism, what's causing it, and what are the comorbidities associated with the person.
Okay, any other questions? Okay.
Hi, Dr. Lee. I have two questions for you this evening. Okay, the first one is, what's the difference between sepsis and cellulitis?
Okay, so the question is, what's the difference between sepsis and cellulitis? So think of sepsis as a global umbrella term. It captures everything at the end stage of all the infection. So cellulitis is basically a skin infection. So a lot of times we say sepsis secondary to cellulitis. So that's what we have. So it's just a global end stage of the infection, complication of the infection.
Okay. My second question is, when I was in Vietnam, I contracted jungle rot. In fact, I contracted it twice while I was there. I was treated for it. Over a period of years, back in 2009, when I was treated by a doctor at Straub, he asked me questions like, were you in the military? Yes. Were you in Southeast Asia? Yes. You know what jungle rot is? I says, yeah. I contracted it twice. He says, you could be having a recurrence of jungle rot. Now, since then, I have been treated by the VA. I do have sepsis. I do have sepsis now, and all they're doing is just treating me. They're giving me antibiotics, but they said it's a chronic thing. You'll always have it for the rest of your life. That's true?
Sepsis is just a condition. So I think you can have infection, ongoing infection, that's hard to cure. I gotta look up what jungle rot, but I assume you're referring to fungal infection, right? It's fungal infection. You can treat it and it can be improved, but sometimes people have. So fungal infections may take a little longer. So you just have to be a prolonged antibiotics course. So it can be treated, but sometimes it may take a little longer. Now, the things that can affect the duration of treatment is how well your ability to heal. So people with poor circulation or peripheral arterial disease, those take longer to heal. And sometimes you're right, sometimes they don't heal, and sometimes that's when they need to like amputate or cut.
Any last question? No? Oh, one more. James, right over there. Oh, could you raise your hand again, ma'am? Thanks.
I wanted to find out about the 3-hour sepsis bundle that you talked about, that the hospitals, I guess that's what they do in ER?
Yes, so you're asking about the 3-hour bundle. So the 3-hour bundle, more specifically, is defined as getting a lactic acid, see if it's greater than, the value looking at is 2 to 4. If it's normal, it should be low, less than 2. If it's 2 to 4, it's considered high. 4 is really bad. And so what lactic acid signifies is signs of end organ damage. That's an early sign of end organ damage. So when the muscles break down, it releases lactic acid. That's what we look for it. The second thing we look at is blood cultures before antibiotics. The reason why we have to get blood cultures is a lot of times in the olden days, we just throw everything at once. So if you get antibiotics first and the blood cultures, a lot of times the cultures won't grow anything. So it's not helpful because the antibiotics are already there circulating, already killing off the bacteria. So that's the second piece. The third piece is you have to give antibiotics, not any kind of antibiotics. You got to hit them strong and hard. So you have to do high dose antibiotics, broad spectrum antibiotics within 3 hours. And the fourth thing is we have to hydrate with 30 cc's per kilogram. So that means for a 70 kilogram, you have to give 2 liters of fluid within 3 hours. So that's the 3-hour bundle that we have to follow. And that's really, really hard to adhere to, especially in this day and age. Because a lot of times you don't get the workup till like 2 hours later, and then all of a sudden you're going to give out that much. So that's why early recognition and get that in is really important.
Yeah, because I was just wondering, because my father went to ER, but he stayed overnight and he died of sepsis. So,
What was that again? Sorry.
no, my father died of sepsis he was in ER.
Uh-huh.
So, and I wondered about the 3-hour bundle, whether they applied that.
They usually do. We've been doing it for the last year. So in the ER, they call code
last year.
We've been trying to adhere to it, but we've been doing it in the last, we're doing the code sepsis within the last year. The hard part about sepsis is depends when you come in. If you come in early enough, then you'll probably be fine. But if you come in like near septic shock, the 3-hour bundle won't save you because that's so late in the stage. It will help, but so that's why early recognition and intervention is key. That's why we want you to communicate with your doctors right away and get that done, treated right away before when it's too late in that time course of the disease.
Yeah, the latest is that, the Patty Duke and that Muppets, the Hanson, because they died of sepsis. And so it made people aware of that situation.
Right.
So that's what made it, I guess, everyone aware of that.
Great. It's not good that he died, but it's great that people are more aware of it.
Yes. Thank you so much, Dr. Lee. Let's give him another round, Dr. Garson Lee, for sharing this evening. I'd also like to send out a shout out to our 2 volunteers for this evening, James Liu and Kimina Fukuda, who came on a Wednesday night. James is a junior at Mid-Pacific, and this is how he chooses to share his Wednesday evening. So that's wonderful of him. Thank you, James. Again, our next Speaking of Health lecture, you might have picked up the flyer. It's on caregiver stress, what you should know. If you're a caregiver, these are some tips you're going to learn about how to cope with the stress, maybe overwhelming stress. We have Dr. Jessica Barry, who is a geriatrician at the Queen's Medical Center. We also just secured two caregivers of hers who are going to share their experiences and what they do. And one of them was, I was just talking to her today, and she said she screams at the top of her lungs. That's how she relieves the stress. Fortunately, she's in an area where it doesn't seem too bad. She's not in an apartment. But you're going to learn things like that. Also, what resources are available, the financial considerations involved in being a caregiver. I would recommend that you sign up for this early because these kinds of lectures always sell out. I mean, it's free, but it sells out really quickly. That's going to be Wednesday, September 27th, 5:30 to 7 p.m. here at the Queen's Conference Center. You can register online or call 691-7117. Your parking tickets can be validated outside with Erin. Please turn in your evaluation forms. And thank you so much for attending this evening. Have a good night.